Dear colleagues from all around Europe, good evening. Greetings from Athens, Greece, and warm wishes for a happy, peaceful, and prosperous year. This is Maria Milona talking from the Hellenic Society of Internal Medicine, and it is a great pleasure and honor for me to host this evening's webinar about nocebo effect, a very challenging indeed entity that impacts the way we treat our patients, the way they comply to the treatments we offer them, and with a significant role in the quality of care that we offer them. So therefore, I'm deeply grateful to the president of the EFIM Working Group, Quality of Care and Professional Issues, Professor Luis Campos, and our co-members who accepted this proposal and made this evening's webinar possible and even organized it. So throughout the procedure, you can write your questions and comments in the Q&A button at the bottom of your screens. And of course, we'll have plenty of time for discussion at the end of this session. Just note, please, that we will accept questions right after the end of Professor Mitsikostas' presentation, who has another obligation for this night.
So, good evening from Athens. I'm Petros Fikakis, and I would like to thank very much the organizers for this invitation, especially Professor Campos and, of course, Maria Milona, who proposed this topic to the Working Group of Quality of Care and Professional Issues of the European Federation of Internal Medicine. So today we'll talk about this very important phenomenon, which is not very well known. I performed a quick search just a few minutes ago in PubMed, and I found for the placebo term, I found 261,000 results. And then I searched for the nocebo term, and I found only 1,120 results. So nocebo is by far less appreciated and less known than its opposite, which is placebo, as we all know. So today we're going to talk about this very interesting phenomenon. Firstly, Professor Mitsikostas, who is an expert in the field of nocebo, will give us the definitions and the pathophysiology of this phenomenon. Dr. Kravariti will talk about the lessons we have learned from randomized controlled trials and observational studies. We will make a parenthesis on COVID, of course. No decent webinar these days is without something for COVID. And finally, together with Evridiki Kravariti, we'll discuss some the communication strategies to minimize nocebo. So our first speaker is Professor Mitsikostas, Professor of Neurology in our university here at the National Kapodisian University of Athens. Dimo, the floor is yours.
Thank you so much for the very kind invitation to be part of this panel with the aim to discuss the nocebo effect in internal medicine, starting with my presentation, which is dealing with the definition and the pathophysiology. Those are my disclosures, both financial and non-financial. Have nothing to do with this presentation this evening. I'll start with a statement. For thousands of years, since man became aware of its existence, medicine rests on placebo. And by presenting a few data, I hope I will convince to believe this statement, because that may change our clinical practice. The whole story began during the War II, when the enthusiastic surgeons observed that they do had much more better outcomes compared to those surgeons that were skeptical. They didn't know that time the phenomenon of placebo, nor the explanation, nor the pathophysiology, and how they could explain that with mechanism in very particular places in our brains. It took a decade when two scientists, James Olds and Peter Milner, were actually torturing rats in their lab in McGill University. They put a catheter into the brain of a rat, you may see here, and this is the X-ray of the rat. And with a bottom, they allowed the animal, by pressing the bottom, to get the electrical stimulus. They see that the animal was consistently pressing that bottom, getting the stimulus, avoiding anything else, even food and water. And that was continuously occurring for days, even for weeks. They thought they discovered the pleasure center within the rat brain. They tried to repeat the experiment into other animals, and they failed. And they failed because they didn't know the exact place where they placed the first catheter. Now, with very sophisticated techniques, with optic nerve stimulation, we can stimulate very small areas in the brain. And now we do know that the stimulus were placed into the nucleus accumbens. And now, based on several other works, we know that the pleasure system into our brains control the placebo phenomenon, let's say, which includes the placebo response and the placebo effect. I will explain later what means each other, versus the nocebo phenomenon, which includes the nocebo response and the nocebo effect. Into the frontal part of our limbic system, there is a network that controls the pleasure, the reward called system. Whereas back, there is another network, I'm calling it the police center, which controls behavior related with fears and other negative behaviors. Those centers into our brains are communicate, and I will show you some videos in rat presenting the entire network. In other very sophisticated with new techniques, we now know that even the striatum is included in this network. And here you see the motivation, which is the pleasure center, and the network that controls the positive behaviors in our life. In a mouse, brain passes through the dorsal striatum, and those are the triosomes. Here in the basal ganglia, let's, because you may are not familiar with the function of basal ganglia, it's basically a motor center. And in the basal ganglia, when we have damages, either anatomical or chemical, we have Parkinson-like responses. But apart from that, we do have areas that controls positive and negative behaviors, and that is very recently discovered. Here you may see in this video, hopefully we will see it, the connection between the nocebo and the placebo center. This is the anterior, and this is the frontal areas of the brain of the rat that controls those behaviors are related to the positive and negative behaviors, including the placebo and the nocebo effect. Because people, they are producing a very valuable acknowledge. and data related to placebo and nocebo are not physicians and are not dealing with patients, their terminology sometimes is very difficult to be understood by clinicians. That was the rationale. We in the European Headache Federation organized a consensus to clarify those terms and to have that understood for those that are producing clinical data in order to interpret that correctly. So placebo is the, sometimes are things, are drugs, or positive suggestions, but are the means that trigger the placebo response or the placebo effect. So it's an intervention, it's a treatment, or even a surgery like that one it was in the World II with the positive suggestion that you will get soon well. So this is the placebo. When we are performing a clinical trial and we are treating participants with inner agents, we are calling placebo, those positive outcomes we are observing after that treatment is the placebo response. And this is a little bit different from the placebo effect. In what they do differ, it differ in the in this component that the placebo response include not only those positive outcomes that are exclusively related to the positive expectation I do have that this treatment will help me instead of harm me, but to other circumstantial factors, e.g. several consisting of the natural history of the disease. There are ups and downs, or a regression to the mean, or spontaneous improvement. All those are included, and we are calling placebo response. On the other hand, we do have the placebo effect that includes only those good outcomes after the placebo treatment that are exclusively related to the positive expectation a participant has. Why would you need this dual terminology? Because if we do want to make trials to investigate the factors that control the placebo, we do need to have exclusively the placebo effect and not the placebo response. In clinical practice, does not matter. We include all those together, and we interpret that all those together. The same way we classify and we say that is nocebo. Nocebo is a thing, is an intervention, is a surgery, is a negative suggestion, just a verbal only negative suggestion. Nocebo response is any bad outcome after the nocebo trigger altogether in a clinical trial when we are recording, monitoring the adverse events that patients report while are treated with placebo. This is the nocebo response. But those adverse events that are reported by patients treated with placebo and that are exclusively related to the negative expectation that this treatment most likely will harm them instead of help them is the nocebo effect. Nocebo response, we do have a monitor by assessing the adverse events of the placebo arm in RCTs and monitors, as I said before, the nocebo response, which is very important in clinical trials Professor Sfikakis and his colleague will explain and present data to convince on that. And it is, of course, associated with lower adherence and higher withdrawal rates in clinical practice. Let's see how we investigate and perform experiments to investigate the mechanisms that are powered the placebo or the nocebo effect. In these very old experiments, you see how Levine discovered or proved that the opioid system controls the placebo effect. We have two groups. They performed dental surgery. The one got just sugar and the other one morphine. Almost 40% of those they were treated with placebo reported pain reduction compared to 85% of those treated with morphine, which is completely rational. When those they were treated with placebo also got naloxone that blocks the opioid system, then they had non-pain reduction at all. And when those groups both were treated with naloxone, none reported any pain reduction, indicating that both pain and placebo are modulating by the opioid system and M receptors in particular. How nice and how simple experiment proven this mechanism. And if we go now to nocebo, how we induce nocebo in experiments, like in that one, Fabrizio, what did to induce nocebo? He performed a pressure, the same one, into two groups, but in one group, the red one, he also told them this toxic information that we're doing, it may induce some pain. And here is the pain rating by those individuals when they took the toxic suggestion. They rated the pain intensity significantly higher than those that didn't take the negative suggestion. But interestingly, the two groups also had significant different concentration of the ACTH of cortisol, indicated that anxiety monitors this clinical phenomenon. All right. When patient pre-treated with diazepam that stops or inhibits anxiety-like reaction, nor the clinical phenomenon nor the biochemical were observed, indicating that anxiety indeed controls placebo and pain. When patients were pretreated with proglumide, which is a holokystokine antagonist, only the clinical phenomenon reversed, but the biochemical did not, indicating that this system controls the clinical phenomenon regardless the anxiety-like reactions. How nice that too, huh? So as I said before, we assess the nocebo in clinical trials by monitoring the adverse events or the proportion of participants reporting any adverse event in the placebo arm. And if we do want to assess the severity of the nocebo response again, we do monitoring the proportion or report the proportion of patients they withdraw from the trial because of the experience any adverse event, although treated with placebo. We performed those meta-analyses in almost all frequent or basic brain disorders. in neuropathic pain, in fibromyalgia, I believe it's a brain disorder, in migraine, tension type headache, multiple sclerosis, Parkinson's disease, depression. And we found that the proportion of patients reported any adverse event in the placebo arm was more than 50%, indicating the frequency of the nocebo. And if we go to see the proportion of patients, although treated with placebo and withdrew because of any adverse event experience, we see that it's from 2 up to almost 10%, which is extremely high. And in this scheme, you may see we have divided the brain disorder into 2 categories. In one where not only brain, but also peripheral nerve system like CIDP, polyneuropathy, we see a very low proportion of patients dropping out from the clinical trial because of the adverse events, although treated with placebo. The rest are around 5, meaning 1 out of 20. And more interestingly, fibromyalgia, Parkinson's disease, and amyotrophic lateral sclerosis, which is pretty close to 1 out of 10. We do have an explanation for Parkinson's disease because basal ganglia, dopamine controls placebo and nocebo effect. That's very nice. But we don't have any explanation for ALS or fibromyalgia. We do believe that very often in this condition we have, as we discussed with Professor Sfikakis, several, let's say, anxiety-like disorder that may increase the prevalence of nocebo in this condition. How can we prevent nocebo response? We are together with Dr. Deliani. We built a couple of years ago a questionnaire. It's very simple. We may deliver the question when our patient is just waiting in outside our office. It's only 4 questions, and if the score is more than 15, then we have a 72 almost specificity, 67 sensitivity, and only 42 positive predictive value. But again, it's very difficult to predict brain reactions with all those networks, and I think this is still a very useful tool to have it in our clinical practice in order to build, as Professor Sfikakis will explain later, strategies to prevent from nocebo. And when we measure the nocebo effects, like with this questionnaire, we found that almost 2 out of 3 people suffering from chronic headaches are presenting an increased QNO score. We do now performing functional MRI studies, which is the protocol, which is the M, first of all, to investigate the brain connectivity between those 2 areas during nocebo responses within the context of a spontaneous migraine attack. The patient is suffering of migraine. We putting him or her into the magnet, and we injecting gadolinium by saying in some of them that this injection may worsen your migraine. This is the toxic information we deliver to these patients. We do have right now around 40 scans. From there, we got only 6 nocebo responses. And when we compare the connectivity of several areas between the limbic network of those people, they produce the clinical phenomenon versus to others they did not produce, we found that there is an increased activation in the left precentral gyrus and decreased activation in the right cerebellar and the posterior part of the right parahippocampal gyrus. What that does mean? It means that particular places in the frontal lobe control, suppress the positive reactions that the frontal reward system may have during the nocebo phenomenon. What a nice result. So, in synopsis, nocebo refers to unpleasant symptoms occurring after a medical treatment that are attributed to negative expectation, e.g. the offered treatment most likely will harm instead of help. Nocebo or nocebos refer to the trigger of the negative expectation, while nocebo response refers to any unpleasant symptom occurring after an inactive, meaning placebo treatment, and includes spontaneous comorbidities. I'm participating in a trial for multiple sclerosis and I'm getting the flu. This is a negative outcome that has nothing to do with the treatment. Still, is a placebo, this is a nocebo response. And then we do have the nocebo effect that refers to those unpleasant symptoms occurring after an inactive treatment that are attributed to the negative expectation exclusively. And I'm getting to statement number 2, that Professor Sfikakis will support that. The more we reduce and we more the increase placebo effect, the more we reduce nocebo. And the more we increase placebo effects, the better doctors we become. I strongly believe with this statement. This is my group. And if you are interested in arts, there is, of course, the placebo bands. I'm suggesting you strongly. This is one of the best songs. Without you, I'm nothing. And if you are interested in movies, this is a just recently released very nice movie called Nocebo with Eva Green, with these beautiful blue eyes. Thank you so much indeed. And I'm once again thanking the organizers to offering me the opportunity to present this data to you this evening.
Thank you too, Professor Mitsikostas. It is a great journey seeing the pathophysiology and clarifying all this terminology for us. Do you see any difference in patients with the nocebo phenomenon because of the different disease they're starting with, because of the different sex they have, or is it a common pathophysiology to all of them?
I'm sure that Professor Sfikakis and Evridiki will present data that there are gender differences, absolutely. And the core disease also plays very important role in nocebo reactions and nocebo-like effects, absolutely. Sometimes we are in the nice position to explain them, like in Parkinson, we do have increased nocebo effects because the dopaminergic system is damaged, and in some others we don't have. The general idea is that the more bad the outcome of a disease carries, then the less nocebo or placebo effects you do have.
It's clear. Thank you. Thank you so much again. Let's proceed to Dr. Evridiki Krapariti.
Thank you so much.
Thank you too, Professor. Let's proceed to Dr. Krapariti, the academic scholar of our Department of Internal Medicine here in Greece as well. A great friend, a beloved researcher who will be tonight with us, and we'll proceed with the RCTs and the observational studies about nocebo in internal medicine.
Thank
Dr.
you so much.
Thank you.
Thank you so much, Dr. Milona, Maria, for all the work we've done together all these years, clinically and also on the nocebo effect. Thank you, Professor Mitsikostas, for clarifying that nocebo is a true neurobiological phenomenon and for convincing us with hard basic science data. And I'm here to talk now about the clinical trial data. And thank you, of course, to my mentor, Professor Sfikakis, for showing me all this world and showing me that nocebo effects are so common, and I was witnessing them in clinical practice every day without even realizing. And hopefully all of the audience today will begin to realize how common these responses and these symptoms are in practice. So I will try to present what we know from clinical trials, because it's now more and more common. Are you seeing my slides turn?
Yes, it's perfect, Dr. Pravariti.
Okay, very good. So as Professor Mitsikostas alluded to, we have come to realize the magnitude of nocebo effects from clinical trials, because evidence-based medicine requires us to have, a placebo arm where the patients take an inert substance. And then we noticed that in these clinical trials, even in the placebo arm, patients would report side effects and drop out of the trial because of side effects, as Professor Mitsikostas mentioned. This is from an old trial of cortisone versus placebo for optic neuritis. And you can see that these side effects that patients report typically will follow the ones that are mentioned in the consent forms. So the side effects that we inform patients of are the ones that they are likely to come back to us as nocebo effects. And the way that we inform the patients and how scary we make it to them will make these effects more common, and perhaps patients will experience them that would not have experienced them if we had a better way to inform them. So you see, for example, with placebo as compared with cortisone, patients report a lot of gastrointestinal complaints, affective disorders, and sleep disorders. So to clarify better what Professor Mitsikostas mentioned about placebo and nocebo responses versus effects, what we observe in an inert substance arm, in the placebo arm, is the placebo response. Some of this, or the nocebo response, some of this bad change in the patient's condition is due to random illness, is due to just spontaneous remission of their disease. It's not all nocebo mechanisms, such as the ones we saw before. If we wanted to really measure the frank nocebo, we would have to compare with the third arm, where the participants would not take any treatment. And actually I have trials like that to show you, but they are not very common. Usually, what we see in the placebo arm, we generally consider a nocebo response. So if we would do meta-analysis of these randomized controlled trial placebo arms for one single disease, we can maybe compare diseases with each other and between them to see which disease setting has more nocebo effects. And so to see for analgesic trials, more patients withdrew from placebo because they thought it was hurting them than because it was not effective. And we saw before that placebo is very effective for analgesia, actually. So Professor Mitsikostas also showed this data that by doing this meta-analysis, we saw that fibromyalgia patients are very prone to nocebo effects, and there are other disease settings as well that I will discuss. Features of the patient are also important for their predisposition to these effects. So it's been shown that females are more easily conditioned toward nocebo effects. So if they take medicine and they experience side effects, the next time they are offered the medicine, they are more likely to have nocebo effects. And this is potentially due to stress. And also some features of the drug. So it is considered that generic drugs are sometimes linked to nocebo effects. And in this large observational study, one insurance carrier switched all their patients on formulary with generic products rather than brand name products. So let's say an antihypertensive would go from the brand name to a generic. So they saw that they gave the patients the option to switch back to the branded product if they were not happy. But they gave two options. About half the patients took a branded name, an authorized generic, which had the same box and the same appearance. and the other, about half, took a simple generic, which had a different box with different colors, so it didn't feel like the branded product. And they observed a significant difference. So the simple generics, they had more switchbacks. They were not satisfied, although the substance was the same in the two categories. And yet another trial and a study on students and a survey on many countries, mostly from the United States, that have shown that people are generally more reserved towards generic drugs in general, and that's something we should keep in mind and perhaps discuss preemptively, that we do believe in their efficacy before giving patients generic medications. Also, we know from observational studies that patients in chemotherapy may have nausea or other symptoms that they have experienced in the chemotherapy suite when they see the chemotherapy nurse outside at the mall or in another place. And that is what we call conditioning, right? They have been conditioned, and now the nurse is a nocebo stimulus for these patients, is causing them these symptoms. About 33% of patients had this reaction in this study. So taking together all these all these randomized and observational trials that have been done for nocebo, we can summarize some categories of risk factors that make patients prone to experience nocebo effects. And of course, some of them have to do with the patients themselves, such as gender, as we discussed, and anxious personality and comorbidities, as Professor Mitsikostas mentioned, some genetic factors. But these are not modifiable. What is modifiable is our own physician factors, the way that we communicate, and we will discuss this in detail in the final section of the webinar, and also some features of the drugs and the healthcare setting. These are modifiable as well. So the ease of access and the lighting and environment where care is delivered, they are important for increasing placebo and reducing nocebo effects. And the way the drug appears, we know that intravenous injections generally are considered more efficacious, have a higher placebo effect. We know that red and alarming colors in the box or the pill may be associated with more tendency to nocebo effects in the predisposed patient. Price is a complex phenomenon. Of course, publicity overstating adverse effects in public, in the television, it has been associated with increased nocebo effects after the advertisements. And different diseases, as mentioned before, carry different risk for nocebo. So now I will go on to present some data on conditions that are very common in daily clinical practice for internal medicine doctors. For example, we know that beta blockers have been associated with erectile dysfunction. Sometimes we may have a tendency to overstate this, and then in this way, we are the ones causing the adverse effects through nocebo mechanisms. So for example, look at this trial. They divided the patients to 3 groups. In one group, they said, we are giving you a pill for hypertension. We're not going to tell you which one is the purpose of this study. And the second group, they said, we are giving you a beta blocker for hypertension. And it has some side effects, but you know, they are not important, and we're not going to go into detail. If you feel anything unusual, mention them. They are not dangerous. And to the third group, they said, we'll give you this beta blocker. It's been known to cause erectile dysfunction. So you see the difference in the prevalence of erectile dysfunction in the 3 groups. The one that didn't really know which drug or if it's really an active substance, they only had 4%, which is probably the true pharmacological prevalence of erectile dysfunction with beta blockers. The second group had 15% because they felt that there are some side effects, so perhaps anxiety was kicking in. And the third group had 30%. So I think we can see that the difference between 4% and 30% is our doing. We are causing this to the patients. And I want to focus a lot on statins because they are so commonly used in practice and because they are so important, life-saving medications in the end. So it's been observed that because of the increased publicity about statin-related myalgias, it's been observed that many patients will discontinue this treatment or not agree to take it, or sometimes even physicians will stop the treatment to patients complaining of myalgias. And this is a big problem for cardiovascular outcomes in the population, enough that this group of the Anglo-Scandinavian trial, cardiac outcomes trial, which is a huge trial with 10,000 and so patients, they looked at their data. They had a blinded phase, and then they had an open label extension phase. And they looked at their data. In the public phase, the reports of myalgia and other statin-related or of adverse effects of interest, they looked at the prevalence of these side effects. In the blinded phase, they were reported equally between statins and placebo. So that was a reassuring signal. And then in the open label phase, suddenly the patients, being aware that they are taking a statin, and this combined with all the publicity of statin-related myalgias, started reporting very increased incidence, 40% more myalgias than they were doing before when they were taking the medicine in the blinded phase. So this created the hypothesis that a lot of the statin-related myalgias are nocebo driven. And then there was this trial last year that actually proved this, that in fact, statin-related myalgias that you see in daily practice, nearly all of them will be nocebo driven and may have to do with even our own providing information on this possible side effect. And so in this trial, this is an N of 1 trial. This is a group of trials, meaning that the one patient will go through 3 different phases of therapy: statin therapy, placebo therapy, and no pill months. And they keep a diary of myalgia symptoms, and they create a symptom score. And they compared the symptom score between the statin months, the placebo months, and the no treatment months. And in fact, they proved that statin month symptoms and placebo month symptoms were equal. The scores were equal. And the no treatment month scores were also there, but about the score was about half. So they realized that, in fact, patients were experiencing these symptoms because of nocebo mechanisms. And they explained these to the patients, and half the patients that were intolerant to statins were able to restart their therapy. And we should be doing this sort of reattribution for our patients who experience statin-related myalgias. Another trial from the metabolic world. This is for GLP-1 agonists given for weight loss. And this is a meta-analysis of 63 studies involving about 20,000 patients. And this is very interesting for the placebo effect, I think. About 5% of them dropped out because of adverse effects in the placebo arm. So the nocebo rate is about 5% in this population, the overweight population, including diabetic patients. But what's very interesting was that in the placebo arm that was receiving an injection with an inert substance, 20% of them reached the 5% weight reduction goal. So this goes to show you that we do need, of course, the drugs, but perhaps not as much as we think. We are not helpless without the drugs. A lot of what we can do goes through placebo. And then another example that is very relevant to rheumatology and gastroenterology, and anyone using biosimilar drugs, and oncology, of course, as well. So it's been observed that when patients change from biologic therapies to biosimilar therapies, which are lower cost therapies marketed for cost savings for the healthcare system. It's been observed that when patients transitioned in the real world to these biosimilar treatments, people were reserved, both patients and the doctors, and they had very high rates of discontinuation because subjectively patients felt it was not helping their symptoms or that they were better with the originator drug. When these drugs were investigated in earlier years, the dropout rates for inefficacy was 2 to 5%. When the drugs when these studies continued to open label extension, there was about 8 to 10% discontinuation, which is expected with biologic therapies. But in the real world, this excess discontinuation and intolerance from the trials to the real world setting has been considered and has been interpreted as nocebo effects. And further proof of that is that when other nations such as Denmark and Holland, the Netherlands, switched to biosimilars after applying specific communication strategies to reduce nocebo and reassure the patients, they did not have these high discontinuation rates. They had the 8%, which was the expected yearly rate of biologic therapy dropouts. And some of our own data. So we started from the observation that osteoporosis, another very common condition in primary care, has very low adherence rate for oral therapies, bisphosphonates, which are the very cost-effective first-line therapies for osteoporosis and fracture prevention. So we asked ourselves if the nocebo effect could be responsible for these low adherence rates, because these are some side effects that also take a lot of publicity. And we performed this meta-analysis, which is very recently published in Osteoporosis International a few weeks ago. And what we found was that in randomized trials of bisphosphonates versus placebo, dropouts due to nocebo were 8%, and that they were higher in older patients. So it's a significant problem. We believe that trials underestimate nocebo non-adherence and dropouts. In fact, so in the real world, it's probably more pronounced. And this old age tendency to nocebo non-adherence in osteoporosis, we've reviewed this problem as well. And it seems that older patients, who are, of course, very common in internal medicine, they accumulate a lot of nocebo risk factors, including polypharmacy, chronic pain, central pain sensitization, and neurotransmitter dysfunction referred to before by Professor Mitsikostas, the other chronic psychiatric conditions, self-stereotyping and ageism. I'm old and medicines hurt me, frailty and dependency, and poor communication because of hearing and vision problems. So there is more research need for adverse effects in this population and how much of it is nocebo. So to sum it up, the nocebo effect causes non-adherence and poor outcomes in practice, and it is quite common. More education is needed of health professionals, such as what we are doing today, to realize the impact of these effects in daily practice and therapeutics. And we're going to go on later to discuss the strategies that should be implemented in our practice to prevent and stop nocebo from sabotaging our efforts, and also for prevention. And I'm going to pass it now to Professor Spikakis to discuss prevention and vaccines. I'm sorry. So we will share the screen again. Okay. Okay, if you can see our screen now.
But they cannot see us. Okay.
Yes, it's fine.
Okay.
So we changed positions. Thank you very much, Evridiki, for this beautiful talk. I hope, actually, I'm sure that Dr. Kravariti convinced you that nocebo phenomenon is very important in everyday clinical practice. There is a very strong example with the beta blockers and the erectile dysfunction, and the stronger example with statins. And actually, there are very convincing data that indicate that 9 out of 10 people taking statins who report myalgias, these myalgias are through nocebo. Only about 10% of those individuals who report myalgias should stop statin. So I think all of us, we have to start discussing with our patients about nocebo and the importance of this phenomenon. But we'll have the opportunity later to talk on how we should talk to our patients and the available strategies. Now, just to proceed and make a small parenthesis and talk a little bit about COVID vaccination and the nocebo phenomenon, which is very important in this era. During the last year, there are several publications on the nocebo phenomenon in patients with COVID. Let's take a look at some titles: Experiencing COVID-19 Symptoms Without the Disease, the Role of Nocebo in Reporting of Symptoms. Experiencing COVID-19 Symptoms Without Having COVID. How do nocebo phenomena provide a theoretical framework for the COVID-19 pandemic? Nocebo-prone behavior in patients with autoimmune rheumatic disease during the pandemic. Conspiracies and the nocebo effect during the COVID-19 pandemic. Very interesting papers. Impact of media coverage on side effect reports from the COVID vaccine. This is very interesting as well. But I'm going to focus on 4 papers on COVID vaccination. And the first one is a beautiful systematic review by Martina Mangio and Dimos Mitsikostas and their colleagues. And what they did a systematic review on the adverse events in active groups and placebo groups, and they compared the percentages in all vaccine trials published during the first year of the pandemic. And this is the AstraZeneca vaccine, and this is the mRNA vaccine. So you can see here that about 20% of individuals that have been vaccinated report myalgias, which could be expected, and up to 10% in the placebo group, the individuals who got, I suppose, normal saline, about 10% of them report myalgias as well. So this is a small nocebo effect, which increases for nausea and vomiting. About 33% in the active group reports nausea and vomiting, whereas about 13% in the placebo group suffers from nausea. This is again a small nocebo effect, not only the placebo group, obviously in the active group as well. And then we come to headache, where about more than 30% in those who got a vaccine report headache versus 30%, about 30%, a little bit less than 30% of the individuals who got normal saline report headache as well. And the same large nocebo effect is observed in fatigue, where about 40% of those who got the vaccine report fatigue versus 30%, amazing, of people who got normal saline report fatigue as well. So these are very important results, and this is the implication of these results, that awareness, eventually awareness of the nocebo effect in these individuals who got the placebo may lead to a greater participation in the COVID immunization and, of course, to a greater protection from this infection, which can be lethal sometimes. Here in Athens, in our hospitals, we performed a survey, a cross-sectional survey, and actually about 1,309 healthcare workers completed the questionnaire that Dr. Mitsikostas showed you before, the Q-No questionnaire, to identify nocebo-prone individuals. As Dimos said before, those individuals who score in this questionnaire more than 15 are considered nocebo-prone. So we had 1,309 healthcare workers. Among them, 18% had declined vaccination. I'm sure you are very familiar with this phenomenon. It happens in every country. Nocebo-prone individuals were about 1 out of 4, about 25% of in our cohort scored more than 15 in this questionnaire, which suggested nocebo-prone behavior. And when we proceeded to a multivariate logistic regression, we found that it was less likely, significantly less likely, to get the vaccine in those participants who scored more than 15, in those who were nocebo-prone. And females, they were less likely to receive the vaccine versus males. And in the opposite, physicians were more likely to get the vaccine versus nurses and administrative staff and other personnel. So we conclude that this nocebo-prone behavior between us, among us in healthcare workers, is associated with vaccine hesitancy. Therefore, the benefit of a campaign focused on the nocebo-prone people, the benefit is obvious and important. And the same thing happens in patients with systemic rheumatic disease. We performed a similar cross-sectional study, and actually we gave this Q-No questionnaire in 561 patients with systemic rheumatic diseases who are followed in our clinic. And at that time, about 80% of them had been vaccinated, and multivariable analysis identified as independent variables for vaccination hesitancy the nocebo-prone behavior, meaning scoring more than 15 in the Q-No questionnaire, negative vaccination behavior in general, and as someone can expect, the higher educational status in our patients was protective. Again, vaccination campaigns should target those patients who are nocebo-prone, and this is important for them and for us, of course. And finally, this is a very nice paper which comes from Israel and was published some weeks ago. So the investigators hypothesized that a nocebo effect would underlie the vaccine hesitancy towards the second mRNA vaccination, that this hesitancy will predict subsequent side effects for the booster dose beyond other effects. And there was a prospective study in Israeli older adults, about 800, and they very sophisticated analysis clearly showed that a meaningful portion of vaccine side effects can be predicted by vaccine hesitancy, demonstrating the side effects comprises psychosomatic, as they call it, nocebo component in vaccinated individuals. And again, this data suggests the need to tailor public health messaging. This is important, and we have to acknowledge this. So I hope that these data were convincing as well. So we have to do something to minimize. We have to do everything we can to minimize nocebo. And Dr. Kravariti is coming back to talk to us about communication strategies.
Okay, thank you, Professor Spikakis. I think it's very interesting, and we've seen a lot of it recently. The pandemic has been a period of very high stress and adaptation in different measures in different countries, but for everyone it's been stressful. And I would say perhaps for women, especially vaccination, because there's also been a lot of conspiracy about fertility and all this has been discredited, of course, but initially I think it has contributed to nocebo effects and hesitancy. So I think it's in our hands. The matter is largely in our hands. It's just difficult sometimes, but I would like to give you now, we would like to give you some tools that you can use in your daily practice, and perhaps it will be a lot to take up. And I'm not suggesting you're going to start using everything at once, but perhaps pick one or two that you like and stick with them initially. So to motivate you, I think you probably are motivated, I hope already, but if you want to sum it up on an individual patient level, nocebo effects will cause distress, will cause non-adherence and therefore poor outcomes, poor quality of life, and distrust in the medical institutions and the doctor himself, because patients are left with the impression the doctor gave me a pill that hurt me, something harmful. And on a healthcare systems level, it will cause patients to use resources because they will come back to the office, to the clinic with side effects where they wouldn't have to, causes us to be frustrated because we can't understand why the patients are not doing well. It can't be explained scientifically, so to speak. And it will lead us to using complex and second-line treatments with high costs, such as in the case of dyslipidemias, and makes interpretation of registries and our own QI projects for preventive efforts and so on. It makes it difficult for us to produce very meaningful data. And in the end, it undermines our efforts for providing cost-effective care. So basically, communication about side effects to prevent nocebo, it has to rely on three pillars. One is to identify and address the patient's negative perceptions that are false, and to try to increase the patient's adherence, and to reduce the risk of patients seeking information elsewhere, which will be not credible and harmful. So basically, we would like to explain the desired treatment's effects more openly and more vividly than the side effects. Sometimes we are more wary of side effects, and we sometimes even fail to discuss why we want to give the treatment to the patient. We only tell them the harmful effects. They don't know the data. They don't know why it's good for them to take statins. We just tell them, we think you should be on a statin, and here are the possible side effects. So the negative message will stick with them, and that's not what we want. Also, it helps to show potential side effects graphically. If the patients see in a bar how likely it is that they do well, how high the good bar is, and how low the possible side effect bar is, then they are more likely to place it correctly in their mind. To help the patients differentiate between the proper medication effects and the nocebo effects. And it's been shown that using videos and giving patients options online is also very useful. Regarding our communication in the encounter, I like the ask, tell, ask model, which is also summarized here in a way. First, we ask, what do you know about this medication? What have you heard? They may have heard something very crazy that we can't even imagine. So we can't begin to correct it if we don't know what it is first. Then we tell, when the patients tell us their understanding, we correct them, we give them the right information. And we do this positively, empathetically, with truthful communication, but positive. And then we ask again, now that I've had the chance to speak to you about statins and their usefulness and the safety, can you tell me how you understand it and what you think about this treatment? So ask, tell, ask. And then when the patients say they are fearful or they are concerned, we don't discredit that, we acknowledge that, and we just try to answer their concerns. So verbal communication should be reassuring. We pick nice words, we avoid the scary words, we avoid the complicated terminology and use a simple messaging. And we ask the patient that they understand, tell me in your own words. And regarding nonverbal communication, we maintain eye contact, we maintain smile and avoid frowning. We keep a calm voice and we are empathetic listeners. And also we make sure to show the patients they are in control and they have their power, that we are not going to force a therapy against their will. So that will enforce their own self-management and reassure them. Sometimes in daily practice, we use phrasing that is not helpful and we don't really realize it. We sometimes express our internal thought process, and that's not useful to the patients. So if we say, this medication may help you, the patient may feel uncertain and anxious, and this is the ground, the fertile ground for nocebo effects. So instead of saying, let's try this drug for you, we can say, I believe this new medication is very good for you and it will help you. It's safe and it's effective. So rather than saying you're a high-risk patient, you can say that it's important to have a plan to keep you safe. It's a more positive wording. And also the patients don't really need to know that they are at higher risk compared to someone else. This is more useful for us, but to them, it only makes them more afraid. And also we don't trivialize patients' worries. Oh, don't worry about that. It's nothing. It's better to pay a lot of attention and say that I am there for you and you can always reach me and we will take care of this together. An example of positive framing. This was a trial that compared two different ways to share information about side effects. One was the positive framing, which was this side effect is uncommon because 90% of people are never experience that with this pill. And the other phrasing was the negative one that said this side effect is common. 1 in 10 people will be affected. And they showed that side effects were 15% higher with a negative wording. So such a simple difference in the way that we provide the exact same piece of information has a significant impact on side effects. So for patients that have already been affected by nocebo effects, and I think these are the most difficult patients to bring back to positive connection with the medication, we can use a technique called verbal mirroring, which is we repeat the phrase of the patient by slightly correcting the more negative and pessimistic parts. So let's say a patient says, after I take my 3rd pill in the morning, I always have a terrible headache afterwards. And then we acknowledge and we validate the patient's feeling. I understand that you have a headache. They truly have a headache. But we try to switch always, substitute always for often or sometimes, because that gives a space for the patient to accept that maybe it doesn't happen always, that you often have a headache. And then we correct the false attribution that this headache, though, is often for many people a sign of caffeine withdrawal. So there we plant the seed of an alternative explanation that is more scientific. And then we divert their attention to from the problem, which is the thyroid pill is hurting me, to a solution, which is I'm going to help you deal with your headache. So this is verbal mirroring. We use the patient's words to give them back the information. And then another important strategy is teaching patients about Nocebo, the way we are discussing this together. And when I was first discussing this with colleagues, this has been suggested by psychologists for a long time, but people were skepticistic because colleagues thought it wouldn't be effective or it may plant the idea of Nocebo to the patients. So in fact, there was a randomized trial about this, and patients were divided in 3 groups. They gave patients lamotrigine, not true lamotrigine, fake lamotrigine, and they gave them 3 groups. In one group, they discussed about Nocebo and what it is. They told them sometimes when patients take pills, they are afraid, and these mechanisms may kick in and they can have unpleasant symptoms, which are created in their brain, basically. And then another group that was just a control. They just gave them standard information. And then a third group just had a negative piece of media on medication side effects. And you can see the difference between the 3 groups and how the group that received Nocebo education had a very low report of side effects from the drug, which persisted even at the end of the session and after 48 hours from taking the pills. So I think this is convincing. And how would you do that in practice? Again, this is preemptive. I would never try to convince a patient they're having Nocebo after they've had Nocebo reaction. Sometimes some patients can be offended by that, and I don't think it would be effective. But beforehand, if you identify a high-risk patient from the factors that we discussed, or perhaps questions like the ones in Q-No questionnaire, I usually begin by saying, sometimes when we are reserved toward the drug or when we are afraid of the vaccines in general, sometimes after we take it, we may experience some unpleasant feelings, such as, a funny stomach or a headache, and this can happen. It's normal, and it's because of stress. So we normalize that you're not crazy, a crazy person, that this is happening to you, and that it's the stress is to blame and not you as a personality. And I find it helps because if the patients have had this talk, when they experience it, they identify it, and they are less afraid of it. So then it may diminish by itself. And of course, stressing the positives of the drug, how safe it is, and how easy it is to reach you, so you can work it out together. And so I think we can conclude the discussion and open it for questions by mentioning again that it's a true phenomenon. It's an enemy of therapeutics. It is much more common in daily practice than we see in trials and than we acknowledge. And that if after it occurs, it's very hard to reverse, and you can't really tell. You can only suspect it's a nocebo reaction, but you can never truly differentiate it from a true pharmacological effect. So it's best to apply preventive strategy by appropriate communication. And I think even after you've had, let's say, nocebo-related myalgia incident, possibly, I wouldn't stop a treatment that is life-saving thing for a side effect that is only nuisance and it's not life-threatening. And it helps to educate ourselves and our patients. And thank you, Maria.
So thank you very much, Enrique, for this really wonderful talk. In order to discuss the nocebo and prevent the nocebo and apply these strategies, we certainly have to know this phenomenon and to appreciate its importance. And we are sure that we have convinced you this evening on this, and we can answer any questions. And once again, thank you, Maria, for giving us this opportunity.
Thank you so much, both of you, for these enlightening presentations. We have a question for Dr. Politi, who would like you to comment on the sex differences in nocebo effect. if you could have a comment, Professor Spikakis or Dr. Gravraiti, and why this happens, or how can we overcome it?
You said about the sex differences.
In Nocebo percentage.
So there is enough evidence to suggest that that men are more prone to placebo comparing to women, and women, it seems that they are more prone to nocebo responses comparing to men. And there are experimental data as well as data from randomized controlled trials and observational studies. Am I right?
Yes, of course.
And this is largely attributed to sex differences on stress levels, and perhaps in some settings on educational conditions, but the latter is not. There are not enough data. But the most we believe that it's a matter of stress.
Okay, thank you. We have the comment of the president of the working group, the Quality of Care on Professional Issues, Professor Luis Campos, who is congratulating all for the excellent presentations. The speakers and you, the speakers, for bringing this interesting and present theme, which we forgot sometimes in clinical practice. He's right. We have congratulations from other participants as well. In the era of fake news and all, we've had experienced this in the COVID pandemic. Do you think, Dr. Gravraiti, that we could implement media, social networking about this nocebo effect to help our patients better?
Yes, I believe, and this is recommended by experts. Also, it's been published in the relevant literature, that we can't really ignore this internet as a source of information. The patients will turn to it, and we're either going to have control by suggesting the sources and by even warning patients that if you go online and look anywhere, the sites that will come up perhaps are the clickbait sites, right, which are exactly built to capitalize on this fear and on producing these stressful situations and these nocebo effects. And we have to protect our patients, and the only way is to provide them with sources, to say, you can look it up here and here and here, and please just don't look anywhere else. But we have to give them a source where they can keep on reading, because we never have enough time with patients to explain everything to them. So we do have to refer them somewhere.
And to gain their trust. That's okay.
Yes.
Okay, Professor Tudelouris, the president of the Hellenic Society of Internal Medicine, asks us if education level impacts on nocebo phenomenon.
This is not very clear. It seems that higher education level is associated with lower placebo, but not necessarily with lower nocebo. So there is not a clear a clear answer.
Yes, but it's also it's mostly a matter of health literacy. So this is linked, but it's not exactly the same thing. You can have someone who's highly educated but has low health literacy, in fact. So we are aiming at health literacy, and not high level, meaning that the type of health literacy that one acquires at school. I think that is important. And I think that this perhaps sometimes even differences between different countries. Perhaps some countries in Europe, for example, since this is the EFIM, have higher health education, general health education for the population, and other countries have less than that. And then sometimes it's also the messaging. In some countries, the general health policy messaging is more positive, in others it's more negative. So these things are important.
In our study in healthcare workers that I showed you before, if I remember correctly, there was no significant difference between the scores in the Q-No questionnaire which defines nocebo-prone behavior between physicians and non-physicians. So
Okay.
indirect
Indication, perhaps.
directly suggests that it's not very important, the level of education.
Thank you. We have more congratulations from our participants. And does the risk of increased nocebo effect in women deserve, just a moment, I lost the question from the participant. You think that cultural, religious, or geographical environmental factors, backgrounds, can also be part of the placebo response besides gender? For example, across the Mediterranean basis? Hero Portincasa from the Italian Society of Internal Medicine asks.
Yes, this is a very, very good point. I'm not aware of studies addressing this matter.
No, I'm not.
Mm-hmm.
I had the same question at the EULAR conference in the summer. It's a very interesting topic. We are not aware of any study addressing geographical differences on placebo and nocebo effects.
I believe that still the nocebo literature is very, it's not,
Emerging.
it's emerging, not large enough. And I'm sure that in some parts of the world, this is an unknown word, an unknown notion.
Even in Europe, I assure you. That's the purpose of our webinar tonight as well. Professor Campos comments that is it possible to speak of nocebo effect about the public communication during COVID pandemics? Is there a difference between people that consult Dr. Google and people that choose not to search for health information in Google, perhaps?
Tell me again, Maria, the second.
Is there a difference between people that consult Dr. Google and people that choose not to search for health information in Google about their nocebo percentage?
Yes, this has been shown. This has been described in the literature that people who go online and do Google search, and even more so people who go on forums for advice about medical issues, this is a red flag for nocebo predisposition. And because it reflects a very high level of anxiety and uncertainty and, you know, despair and somatization many times. And
so extensive search in the Google and participation in chat rooms of patients they have been shown that are associated with higher nocebo responses.
Yeah, it's the same as obsessive reading of the patient information leaflet. And actually, we should be advising patients that what is on the leaflet is largely a disclaimer and not really, you know, relevant and common. So for the older generations, it was the leaflet. For newer generations, the leaflet has been replaced because they can find the leaflet online. So they look for everything online. And also, we don't have enough time. And I think if we give a little more time, patients will not feel incomplete. Yes, that they don't have enough. And we can have pre-created, you know, a patient information leaflets and online sources for them to look there. And also there was another part of the question.
That's okay.
Yeah.
Can we proceed with another one? Does the risk of increased nocebo effect in women deserve a personalized strategy, a gender attention? Can we do something more about women specifically to prevent it?
Yeah, it's still I think it's unexplored. We say it's probably stress. It's kind of difficult to research this. I am wondering how much of it has to do with fertility and concerns about effects of drugs on fertility for women, because we kind of know that we have all our cells already. So I think women are generally perhaps more reserved for this reason as well, but that's just a hypothesis. So it's worth looking into. Yeah, there's many things that one could say, but I wouldn't want to go on with uneducated guesses, but I think it's worth investigating.
Thank you, Dr. Ravaithi. And
Many unexplored issues. concerning Nocebo.
Okay, we have more to learn in the near future. And Dr. Spikakis, closing this evening's webinar, do you have a comment on beyond the nocebo effect, on Nocebo effect? Can you give us some highlights?
Nocebo. Okay, so there are more funny words like Nocebo and placebo.
We have something on this.
And
thank you.
We were expecting these such questions. So
yes. So we say that to be accurate in terminology, we speak about nocebo when there is an inert substance. And when we are talking about the nocebo-mediated adverse effects of actual drugs, we may want to call it a nocebo effect. That's the only difference. But you will find it in the literature about statins. There are several reviews referring to the nocebo effect. So it's nothing extra. It's just the nocebo aspect of drug side effects.
Okay. Okay. Thank you so much.
Let's close it if you want with Europe and Europe acknowledging the need for holistic medicine from the years of Plato to very recently to the 21st century, that in order to heal, we have to start by curing the soul, is Plato.
Thank you for this comment, Dr.
Should never forget what Lon, who got the Nobel Prize, said, that words are the most powerful tool a doctor possesses, but words can maim as well as heal, because they can function as a two-edged sword.
Thank you so much for these considerations. Thank you for tonight's webinar. Thank you all the speakers, Professor Spikakis, Dr. Kravariti, of course, Professor Mitsikostas, for this very enlightening, I think, webinar for all our European colleagues. We've talked about a very challenging entity. We underlined its pathophysiology. We unmasked it as an important factor for the quality of care we offer to our patients. And perhaps, as Professor Campos said, it's really the time to refocus in the art of medicine, reconnecting with our patients, talk to them a little bit more, care about their nocebo phenomenon, and perhaps this was the first for more to come about the nocebo awareness in Europe, and not only. We have another reminder, just a moment for me to show you that in the upcoming March, we have our Congress here in Athens, and we're waiting for all of you to come. Just a slight reminder for me. Murat, if you could please share my screen, I would be delighted. This is for you, not to forget. Please join our upcoming Congress. Please, we will be glad. You'll hear more about nocebo. You'll hear more about other very interesting topics that we have to share with you in the upcoming Congress. Thank you all. Thank you for your technical support at the Delta Communication. Thank you from our beloved secretary, dear Aneta. And thank you all for joining us tonight. I think it was a very enlightening experience for all. Thank you. Good night.
Thank you, Maria.
Bye-bye. Good night.
Bye.